Good afternoon, Chair. Your meeting is now live.
Thank you very much, Peter. Good afternoon, everyone, and welcome to the Health Overview and Scrutiny panel. I'm Councillor David Fuller, the new chair of this panel, replacing Councillor Chris Atwell. And I wish to also thank Councillor Chris Atwell for all his commitment to this panel in the past. I'd also like to welcome this afternoon Councillor Tom Wood as a new member of this panel. We are here meeting virtually in response to the limitations placed on the governance by the COVID-19 pandemic. Until recently, the law stated that all members had to be present in a room to make formal decisions at meetings. However, the law was amended to response to the COVID-19 emergency, and the councils are now able to hold public meetings virtually. This is in accordance with the local authority coronavirus flexibility and local authority meetings regulations 2020 number 392, the regulations. Members of the public are invited to view this meeting here this afternoon. Those present are requested to keep their microphones on mute and to only turn them on when they are called to speak. Members are requested to keep their cameras turned on at all times. Officers are requested to turn their cameras on only when they are presenting their reports or answering any questions this afternoon. If anyone would like to speak here today, please would you write the RTS, and that means request to speak, in the chat function. Each time you wish to speak, please say that if you could please make sure that that is the only thing that we're using it for, please. I would now like to invite those present to introduce themselves, members and then officers and then any external representatives. So I'd start off with the members. So Councillor Lee Mason, who's my vice chair. Councillor Lee Mason.
Good afternoon, Councillor Lee Mason for Cosham Ward. I'm having a few technical problems at the moment, so we'll be having the camera on as soon as I can.
Thank you very much, Councillor. Councillor Graham Heaney, please.
Councillor Graham Heaney, St Jude Ward.
Thank you very much, Councillor, and welcome. Councillor Leo Madden, please.
Councillor Leo Madden, Nelson Ward, Portsmouth City Council.
Thank you very much, Councillor. Councillor Steve Weems, please.
Councillor Steve Weems, Portsmouth City Councillor for Drayton and Farlington.
Thank you and welcome. Councillor Tom Wood, please. No? Okay. If he comes in, Lisa, just let us know. So Councillor Tom Wood isn't present at the moment. Councillor Vivian Archwell, please. I think I've said that correctly. Present at all? I called her name again. Councillor Vivian Archwell, Winchester City Council.
I'm just looking, Chair. I don't think she's present.
Okay, so that's fine. Councillor Arthur Algate, please.
Pronounced Agate, Chairman, and I represent East Hants District Council on this Health Oversight, Overview and Scrutiny panel for South East Hampshire and Portsmouth.
Thank you. Thank you very much, and a big welcome to you. Councillor Trevor Cartwright, please, who's from Fareham Borough Council.
Yes, thank you, Chairman. I'm Councillor Trevor Cartwright from Fareham Borough Council, currently Deputy Leader and Executive Member for Health and Public Protection. Thank you, Chairman.
Thank you very much, Councillor, and again, welcome to you. Councillor David Keast, Hampshire County Council, please.
Yes, Councillor David Keast, Hampshire County Council and Vice Chair of the Health Overview and Scrutiny Committee.
Thank you very much, Councillor. Welcome. Councillor Philip Rafali.
Chairman, well said. I'm Philip Raffelli. I'm a councillor from Gosport Borough Council. Thank you very much.
Thank you and welcome. Councillor Rosie Rains, please. I think I'll present.
Good afternoon, gentlemen. Thank you. Rosie Rains from Havant Borough Council. Thank you.
And a big welcome to you all. Now I'm going to introduce the officers and external representatives. Andy Biddle, Director of Adult Social Care here in Portsmouth City Council. Andy, would you like to introduce yourself, please?
Good afternoon, Chair. Thank you. My name's Andy Biddle. I'm the Director of Adult Care for Portsmouth City Council.
Thank you for coming and thank you for your time as well, Andy. Ron Shields, please, who's the Southern Health Foundation Trust. Have we got him here?
Thank you, Chair. Yes, hello. Ron Shields, Chief Executive of Southern Healthcare.
Thank you and welcome again. Nikki Adamson Young is the Director for Portsmouth and South East Hampshire NHS Health Foundation Trust.
Nikki has sent her apologies for this meeting. I'm afraid she's tied up operationally, so I will cover what Nikki would have otherwise done.
Thank you very much, sir. Tracy Redmond, please, Head of Operations, please. Have we got Tracy with us?
Good afternoon, Tracy Redmond, Head of Operations, South Central Ambulance Service.
Good afternoon, Tracy, and welcome, and thank you for your time as well. Penny Emmerett, who's the Deputy Chief Executive of Director of Strategy and Performance. I think I've said that correctly.
Chair, Penny will be joining us about 2:30 later on in the meeting.
Okay, thank you very much. And yourself, Lisa Gulcher, Democratic Services. Lisa, welcome, and introduce yourself, please.
Hello, Chair. Yes, I'm present from Democratic Services, taking the minutes today.
And we've also got a John Waite who's observing today and learning the ropes, as they say. So a big welcome to John. John, do you want to introduce yourself?
Jonathan Waite, Democratic Services.
Thank you very much, John. Anybody else that I've missed at all, Lisa, so far with the roll call?
No, I think that's everyone present. Thank you, Chair.
Thank you very much.
David, sorry to interrupt.
Yes.
It's Councillor Cartwright. I've got to mention I do need to leave at 3:30 because I have another Teams meeting thereafter.
Thank you very much. Thank you very much, Councillor. We hope to be finished by then, but who knows? Thank you very much. So we move on then to apologies then for absence. Have you received any apologies at all today, Lisa, please?
No apologies, Chair.
Okay. Members, we move on to any declaration of members' interest at all. Members, any declarations of interest?
Yes, thank you, Chairman.
Steve
Weeks. Wrong party.
Yes.
Yes, I work for the NHS in the South, Central and West CSU. It is not prejudicial interest and there's no decisions today. And as a public body, it does allow me to attend. But nonetheless, I think it's pertinent I make that declaration so people are aware.
Thank you very much, Councillor Weems. And I'd just like to say that I've got a personal one, a bit like yourself, that I run a residential care home in Cosham, but there's no voting such on here. So it's just for me, it's just personal, but it's just so that people are aware of that. So thank you very much. Any more declarations of members' interest before we move on, members? No, okay then. So we move on to number 3 swiftly. Minutes of the previous meeting, and that was held in September. Members, you've all looked at the minutes of that meeting, and I'll take it you've all had a copy of that. Could I have somebody to approve the minutes, please, and a seconder? Who would that like to be, please?
I'll move the minutes, Chair.
Thank you very much. Councillor Leo Madden has moved the minutes. Can I have a seconder, please?
Happy to second.
I'll
Chair.
second.
Right. Sorry, who was that, first of all?
I think there were 2 of us.
Yes. I think someone just got in before you, Councillor. It was a gentleman. I can't remember which one, but
no, ladies first, by all means.
No, right, okay.
Seconded, thank you.
Thank you very
You're
much.
a gentleman.
Thank you very much, Councillor. So those have been approved. That's absolutely fine. Thank you very much. So matters arising from the September's meeting, members. Lisa, did you want to say a little bit about the Primary Care Committee? There was a little bit on there. Obviously, I wasn't here at the time. Could you just inform us on what's happened there for minutes arising, for the matters arising?
Yeah, of course. So one of the actions from the September meeting was regarding the Hanray Road merger. So the minutes of the Primary Care Commissioning Committee, where the decision was made, they were circulated to the panel on the 29th of October, and also the link to the public report. So those have been circulated to members, and we'll include the link in the minutes for today's meeting for any members of the public that are interested to see those.
Thank you very much, Lisa. Members, anybody want any clarification on that at all? We quickly move on. No? Okay, thank you very much. So now we're going to move on to the first item, or item number 4 on my crib sheet, is the adult social care update. And this is pages between 9 and 20. Can I remind members that it's questions on the report, please, we're asking, not really statements. So I'd like to invite Andy Biddle, please, to give a brief update on the report that's in front of us. And that's pages between 9 and 20. Andy, over to you, sir.
Thank you, Chair. Good afternoon, members. I'll apologise in advance. I have a particularly vocal cat with me this afternoon, so if he decides to give voice, I'll apologise in advance for him. So the report before you is covering adult social care, Portsmouth City Council, the period between April and September 2020. And what I've listed there is the majority, in fact 99% of our activity during that period was obviously related to the COVID-19 pandemic. I've talked about the priorities that we had in that period. They boiled down to those 3 priorities in terms of maintaining critical services, complying with all the legislation and guidance, and working subsequently toward the restoration and recovery of services. And I've listed at 4.2 some of that guidance that came out from the Department of Health and Social Care in the main for adult social care to follow over that time span. Haven't managed to list everything because there was, as I'm sure you're all aware, an extensive amount of guidance that came out through the gov.uk website. It's particularly pertinent in Portsmouth, the responding to anything like a pandemic, any kind of crisis, that we have quite a strong history, foundation of integrated working between ourselves and our NHS colleagues. And so I've detailed some of those arrangements that we have in place in Portsmouth. I think it's fair to say that if it wasn't for those arrangements, our response would not have been as strong as it could be in terms of supporting both our providers of care and health in Portsmouth, and also the citizens of Portsmouth that make use of those services. So it's worth a mention that integration has really strengthened our response. Then moving on to point 6 onwards, I've tried to pull out some of the significant themes that were needed to be dealt with by ASC over that time period. You'll be aware of many of these because they received sufficient press both nationally and locally. The first of those was personal protective equipment, and a paragraph doesn't really feel like it does it justice given the amount of time that particular difficulty felt like it went on. But what we managed to do fairly early on was establish a strategic reserve at a local level, and invite any provider of care in Portsmouth who was having problems with obtaining PPE to come to us, and we would issue them with emergency supplies for up to 48 hours. We then moved on to a more solid footing as we found more of our stocks coming in that we'd ordered, and we're able to just say to any provider, if you need any PPE at all for any reason, come to us and we'll make sure you've got it. And we did that really to ensure that we were working as a city, and that any citizen who needed care and support in Portsmouth could gain access to the right PPE from their provider without any distinction of who the employer was. Moving on, linking to the wider support that was available for care providers in Portsmouth. We did a daily sit rep, as many organisations did, to understand what was going on across the city, where we were seeing staffing shortages, where we were seeing outbreaks, where we were seeing problems that we felt we needed to be involved in and help people with. And we also established very regular meetings with any provider from any kind of sector, be that a care home or domiciliary care environment, supported living, day service, and tried to have regular question and answer sessions and virtual meetings such as these on a very regular basis, so that we could keep in touch with what was going on in our community and try and nip any problems in the bud as quickly as possible. There were significant financial challenges in the sector. There have been for many years. And what we didn't want to see was a collapse of any of our providers when they were, especially in the middle of a pandemic, when we were seeing more call on their services. And so we put in place some financial arrangements, as most local authorities did, and I've detailed them there. There were three main thrusts to that. The first was a minimum income guarantee, so that if people had particular voids in care homes, for example, that we paid at levels pre-pandemic, to try and give them some stability. The second was to pay for PPE if they were able to obtain it, and the third was to pay for extra agency staff where they needed them because they had staff sickness going on. What we also managed to do was maintain an excess of domiciliary care in the city throughout that time. And when we had 4 care providers come to us and say that they had particular problems with staffing and couldn't get agency in, we were able to put that domiciliary care excess in to help them over a period of 1 or 2 weeks, no more than that, but just to keep that care offer stable, so that people could stay where they were receiving care in their familiar environment. So that was really helpful. We saw an impact on our own care homes as well of about 30% staffing absence. And so we did some overstaffing and some agency staffing to keep providing safe care. So a fairly challenging time, but I think we managed to respond to it. I then talked under 6.3 about the folk that were shielding, those folk that were clinically extremely vulnerable, and the work that we did together with the Hive to ensure that medication, food, the vitals, the essentials were delivered to people when they needed it, to manage the data that was coming down from national government. And also to provide some companionship, because for a lot of those folk that were shielding, it was a fairly lonely time. So trying to keep in touch with them and have a regular contact. I talked about hospital discharge. That was a real focus throughout the pandemic, both in terms of at the beginning preparing NHS beds so that there was sufficient capacity for the surge, and ensuring that people could come out into the right place, working with NHS Finance, to ensure that we knew where people had gone when they'd been paid for to come out of hospital, and then picking that up afterwards to work with our colleagues in the CCG to carry out assessments for people who receive care and support funded by the NHS during the first wave of the pandemic.
Sorry, Andy, can I stop you there? Sorry, yeah. Andy, just if I can just stop you there. Just a couple of things, members. I noticed Councillor Councillor Tom Wood is now with us. So thank you for coming. Just any declarations of any interest at all, Councillor Wood?
No interest, Chair.
Thank you very much. Had Councillor Leo Madden who wanted to speak. Councillor Madden, did you want to wait till after Mr. Biddle's finished, or did you want to come in now?
Sorry, Chair, I was trying to get in early, that's all, but obviously let Andy finish his report.
Thank you very much. Sorry.
No problem.
Back to you, Andy. Sorry to interrupt.
Thank you. No problem at all. I then talked about the National Social Care Action Plan, which asked us to enable a facility where somebody couldn't go to a care home because they couldn't have isolation care post 14 days from hospital. And we established a unit in Harry Sotnick House to do that, and we're still doing that at the moment. And we're in negotiation with the Care Quality Commission around the new designated premises guidance that we've seen as we speak. But we continue to have a unit. The Gunwharf unit takes about 20 people. We continue to see good occupancy and turnover so that we can bring people out of hospital and give them a breathing space to decide where their onward journey is in terms of their care needs, but also to provide safe care in isolation so that we don't see any spread of COVID infection. Very sadly, under 6.5, we experienced losses in the city, both in terms of in the PCC care homes and in independent care homes in Portsmouth. The fact that this is a really easily spread disease, and that a lot of people in care homes were most at risk from dying, doesn't really take away from the impact that has either on the people that surround them, their families, or indeed the communities that build up around care homes. And we found ourselves reacting fairly quickly to put some wellbeing support in, not only for our staff, also accessing wellbeing support for care providers in the independent sector and for the families who'd been affected. Thankfully, we've had a longer period without any deaths in our care homes in the city, but it's always a really trying time. And so we're really grateful to our HR colleagues for supporting us with that. We saw some inspections, arm's length inspections from the Care Quality Commission, which we passed in PCC care homes. And as soon as we began to see a drop in infection levels and start to move into a recovery phase, understanding we'd be seeing a second wave, we started to open up respite services as much as we could, and we're still on that journey because they weren't considered critical in the first wave. But what we're trying to do is keep them open in the second wave, because the impact on informal carers of not being able to gain respite is particularly significant. And we saw that during wave 1. There's some comments under 6.9 around some of the work we did, particularly with people with learning disability during wave 1, how we kept in touch with people, how we provided alternative methods of contact for people, using resource packs, easy read guidance, that kind of thing, and emphasising the importance of hygiene, hand washing, that kind of thing for people in that particular definition. I then come on under 7 to put in some demand figures. We saw quite an increased demand for care during wave 1. We still have the tail end of that with us today. I think we've got around about 3.84% increase where we'd normally be at this time of year. And we won't know for a little while, but we think that might be a longer term increase. Not necessarily the effects of something that's been called long COVID, but certainly people needing care and not able to move on from that after the COVID period. So there's various tables there under those pages of the report giving that giving those figures and showing increases and decreases in where we spend the city's money for residential care as well. I talked a bit about deprivation of liberty safeguards under 7.3. And we haven't reported applications for this time period, which we normally would, because it's just they've been skewed, and the number of applications and how we've been able to respond. But we are anticipating now that the new scheme, the Liberty Protection Safeguards scheme, will not be with us until April 2022 at the earliest, because of the impact the pandemic's had on planning for that. I would intend in our next report to come back with those figures and to get back on an even keel. Then I've talked under 7.4 about Mental Health Act assessments. We continued with our 24/7 service during pandemic. It was touch and go. We had some approved mental health professionals who were infected and did become unwell because their work has to be face to face. But we managed to maintain the 24/7 rota, which is a real testament to their dedication. And I then finished talking about how the adult safeguarding team worked during wave 1 of the pandemic, and how in common with other services, we've seen a referral after that wave, if you like, almost the effect of wave 1 really on adult social care has come after wave 1 for the rest of the country. So I think in summary, that hasn't covered everything that was done, but that's quite a lot of the work that was done. I hope that's brought out the main points of the work adult social care was doing and emphasised the integrated nature of our services across the city. I'll pause there. Happy to take any questions.
Thank you, Mr. Biddle, for that thorough report, I must say. Councillor Leo Madden, you had a question, please, to Mr. Biddle, please. Councillor Leo Madden.
Thank you, Chair. In fact, I've got 3 or 4 questions, if that's okay.
Yes, please.
Andy, thanks very much for your report, and thanks very much clearly to all the staff involved in these difficult times for us. But there was a couple of questions arising from your report I'd like to ask. At the top of page 11, you talk about the Primary Care Trust handing functions over to the Chief Executive of Portsmouth City Council. I was just wondering, would these be medical things, given that these are medical professions and the Chief Executive is not? What kind of examples are we talking about?
We wouldn't be talking about clinical functions. The clinical commissioning group is mainly a commissioning body, and therefore it will be ensuring that there was sufficient provision of services in Portsmouth. But most of the clinical functions tend to be provided through providers such as Solent NHS Trust. So it would be the functioning of the CCG as a day-to-day organisation in what it commissions, how it ensures that the healthcare needs of people in Portsmouth are met. And it's a fairly important thing for us because it's joining up that health and care offer at a very local level. And I think one of the things about local government, one of the things about adult social care is you can reach out and touch adult social care at a local level. If someone wants to get through to me, a citizen, on the number 10 bus, they can do. You know, we're local, we're in the city, we're accountable. And I think the CCG is very much fixed on achieving that. So it wouldn't be clinical functions, but it would be commissioning functions, day-to-day healthcare commissioning in Portsmouth.
Councillor Leo, madam.
Okay, thank you. Andy, could I move on to, you talked about hospital discharge, and that's fine. Something that we've been concerned about for years. But can I say that did social services, social care, recognise at the time of the first lockdown or the first outbreak that that people in our care homes could get COVID or indeed die because of COVID? And did we take any particular actions? I just say this because I recall now, because I wrote it down, found it, that I asked a question way back in one of the coronavirus meetings that we had about people visiting them. And I meant people coming in, making deliveries and all sorts of things at the time. But I'm not too sure I got a particularly good answer on that, Andy. And can I just say, Andy, that there's a massive misprint. The unit the unit also provides an opportunity to discharge to excess, I presume it means.
Couple of questions there, Mr. Biddle. Could you answer them from Councillor Leo, madam, please?
Certainly. So what we had guidance in March originally, hospital discharge guidance, and that was to prepare the NHS to be able to cope with the expected peak, particularly for people that required oxygen of some description but would have needed hospital care. So initially there was an effort. The discharge happened very quickly. It was paid for through NHS funds. And I think the picture around infection prevention and control, which is the key bulwark against COVID-19, was developing at the time. We had some initial guidance. We'd started to access PPE. We'd ensured that our care home staff had the PPE in Portsmouth City Council, but the guidance evolved over time. So I don't think, reflecting back, I don't think there was a full realisation as to risk. I think there wasn't, in fact I know there wasn't at the time a testing regime so that people being discharged weren't necessarily tested for COVID-19 before they went to a care home. I think when they came into a care home, the PPE was there, the guidance that was there at the time was being followed. And as soon as we had any kind of outbreak or exposure, we would approach Public Health England, the health protection team, and get advice on what to do and how to best care for people. And we rapidly evolved into caring for people into isolation before government guidance said you should on that basis. But I think, did anyone realise what was going on at that time and the huge risk? I would say not. That's personal opinion. But I think we learned fairly quickly.
Okay. Did you?
No. Except it was a national issue, but I just wondered, when it was raised earlier on, where we thought, aha, there could be a problem here. We'll do something about it without waiting for guidance or whatever.
Yes.
But however, thank you for answering that. And my last question is to you on deprivation of liberty. You're absolutely right. We were expecting some. I think it was to make things easier on the deprivation of liberty safeguards. This I think you call liberty protection safeguards.
Yes.
And the figures have been going up. We haven't got the last lot, as you say, Andy, and they'll be given to us at some stage. But the figures appear to be going up. You do say that it's likely to need specific project management and a dedicated training source. I think that probably goes without saying, doesn't it? Does it also mean getting more staff?
I don't think we know. I don't think so. I think we will probably have sufficient staff, and this is going to be a question that will, or an answer rather, that will evolve over time when we see the full impact. But from what we've seen of the guidance thus far, we think it's a project management and training piece, so that everyone knows what they're supposed to be doing, and that we can change from what we're doing currently, which is under the deprivation of liberty safeguards, to the LPS arrangements and procedures. But it's difficult to say at this point. What we really need to see is the code of practice published. Because even when we see primary legislation, until we see the code of practice which tells you how to implement primary legislation, it's really difficult to judge. An example being the legislative tool of the Mental Capacity Act in 2005 was a fairly thin document. The code of practice was a fairly thick document and gave us an understanding of how we worked with that particular piece of legislation. So I think at the moment, no, but we will need extra staff to bring it in, but that will probably evolve.
Thank you very much, Mr. Biddle. Councillor Madden, if you want to come back after I've taken a few more than welcome. Just write an RTS in the group chat there, please. Thank you very much. Okay, so the next person I've got is Councillor David Keast, please, who's from Hampshire County Council.
Thank you, Chairman. 6.5 refers to bereavement, and probably one of the saddest events of this COVID period has been what in fact is excessive deaths in care homes, and quite a lot of this has been caused not by the residents being what shall I say, doing anything wrong, but purely by discharges from hospital infected, which have infected the residents, and staff bringing it into the homes. What was the situation regarding your own particular cases? Did this happen, and what did you do to prevent it in future?
Mr. Biddle.
Thank you. So we firstly organised ourselves a stock of personal protective equipment, and we ensured that was a stock that we could draw upon without shortages. We then trained our staff in the best guidance that we had at the time, and as I say, that's evolved probably 4 times over the course of the pandemic, I think, to my knowledge. And so each time we updated in training. We also called on the resources of our colleagues in the CCG. There's an infection prevention and control expert in the CCG, our Director of Quality, and she has a small team. And so what we did was, whenever we were planning to do anything, whenever we were planning to do any training, we asked them to come and certify it for us. For instance, when we set up the Gunwharf unit that would care specifically for people in isolation and had a separate entrance to the rest of the home and all that kind of stuff, we got the team in to certify that for us and to go through one of their audits to make sure that we were doing what we should be doing with that. Whenever we had any kind of COVID positive infection, so when somebody tested positive, we would consider whether we closed the wing down that they were on, as in cared for all of those residents in isolation. We also did something that we called cohorting. So if we had 2 or more folk that were COVID-19 positive, we'd care for them in a particular area. That eventually led to the unit that we opened, the Gunwharf unit, which, as I say, is isolated from the rest of the home. Separate entrance, separate lift, separate food preparation, all that kind of stuff. And so became our isolation unit for anyone that was C19 positive. So those are a variety of those things in the way that we responded. I think it's true to say, and I guess most of my colleagues nationally would probably echo this, I think it was a learning experience. So we learned as we went along. As we saw each new piece of guidance, we adapted to it. And I think what we then had was a very long period without positive infections and without deaths. And thankfully, at the moment, we haven't seen any deaths for some little time.
Thank you, Mr. Biddle. Councillor Geese, did you want to come back again for another question?
No, I'd be very interested to know if he does know what the numbers were of the people that were actually discharged from hospital with COVID into the nursing homes.
I can't give you those numbers off the top of my head, I'm afraid. I would be able to get the numbers of people that were discharged from hospital, but not that were COVID positive, because unless they had a test, which for much of wave 1 they didn't, we couldn't tell. We could see if someone was symptomatic, for example, so if they had the symptoms of COVID, but unless there was a test, until whole care home testing was then subsequently introduced, we couldn't tell if they were COVID-19 positive or not.
But would you agree that the numbers weren't really acceptable?
I think the number of people that were symptomatic caused us some issues at the beginning. I think as guidance evolved and as the government introduced that nobody could be discharged from hospital care and without testing, it got better. But I think it was a struggle in the beginning.
Thank you.
Thank you. Mr. Biddle, would you get back to the committee, please, or the panel, with what Councillor Geese has asked about the numbers? Could you get back to us certainly before the next meeting so we can say that in the minutes, if that's okay? Thank you very much. Councillor Geese, did you have any more questions, or can I move on?
No, that's fine. Thank you, Chairman.
Thank you very much. Councillor Graham Heaney, please. A question to Mr. Biddle, please.
Thank you, Chair. Well, actually, I have a number of questions, and actually, I had a couple of people email me to ask some questions about the report. I'm not quite sure how they found out about it. I know I sent this to some of my council colleagues saying it was coming up, so maybe it came via that. And one person I do know who has sent some questions. So I'll try and keep it short. Some of them are just factual, some are from me to just get some clarifications. Hopefully I won't take too long. There's one thing I didn't quite understand, and maybe I understand it under something different. In paragraph 5, you talk about Scheme 1 NHS funding. I must admit, I couldn't remember what that meant. I may know it under something different, but I couldn't be quite sure I understood what it was. So that's me not knowing my stuff.
Not at all. Thank you, Chair. Not at all. I think there's been a great many things that have been open to misinterpretation, so I don't think it's you. So Scheme 1 funding, essentially from the hospital discharge guidance that was published in March of this year, the NHS was committed to pay for anyone coming out of hospital in terms of whether they needed residential care or whether they needed domiciliary care. So that was seen as Scheme 1 funding. The government subsequently announced, and that was open-ended. The government subsequently announced that that would end on the 30th of September, and then from 1st October onwards, there'd be Scheme 2 funding, which was that anyone coming out of hospital who had reablement needs or rehabilitation needs would be receive NHS funding for 6 weeks after that, and then revert to local authority funding as appropriate. So Scheme 1 funding was open-ended during Wave 1. That ended on the 30th of September. And I've referred in my report, I think, to the fact that we're engaged currently in assessment for those people that are still in receipt of Scheme 1, because there's a requirement to move all of those people onto either social care funding or, if appropriate, continuing healthcare funding no later than the 31st of March next year.
Okay, thanks. That's helpful clarification. It's quite complicated. The question I received from someone else, they asked about people who get direct payments, and they said, would they have to deal with ensuring their providers had PPE? I don't think they do have to do that, because it's the providers who deal with PPE, isn't it? It's nothing to do with the people. Well, that's clarified that then.
There is, sorry to interrupt, Councillor, there is a slight distinction on that. So it very much depends whether somebody who's in receipt of direct payments is employing someone as a personal assistant, which is a direct employment contract, or through a care agency. So ordinarily through a care agency, they'd have their own PPE, they're an employer, big employer, or large area employer. If someone was employing a personal assistant and that personal assistant wasn't self-employed, which makes it even more complicated, then they can come to the local authority and we'll provide PPE for them, or they can purchase their own and include that in their invoice if you like. But the should be that nobody who's in providing a care and support role should be without the PPE they need.
Okay. Next one is my one. It's about provider support. You mentioned that we had to step in to provide support. I know we got things like the infection control grant, but did we get fully compensated by government for all the extra costs that we undertook to do the things you covered under provider support?
That's a difficult one, I think. And I think we probably need to ask Mr. Ward about that as the 151 officer. My understanding is that we have a shortfall in the council of some millions, even after all of the government support. I think it's probably reasonable to say that that's reflected nationally when we've heard councils in the press and what the LGA has said itself. So we did see an amount, two grants of around about 1.6 billion, I think, nationally, and Portsmouth obviously got a share of that. And that was paid to local authorities. Adult social care was mentioned in that. It wasn't exclusively for adult social care because it talked about children's social care, and it talked about, I'm sorry, my memory's failing me, it talked about 4 or 5 other areas of council funding that this was meant to compensate for. So I think a fair answer from my standard of expertise would be that we saw quite a lot of compensation from government, but as a council we still haven't had full compensation from government for expenses.
Okay, that's fine, thank you. I'm sorry, I've got one from one of my emails. Can I do one more?
Yes, of course you can, Councillor.
It's about testing. Someone asked about agency staff who come into a care home. They may work for a day or so in one care and then move on to another care home. Now, when they test, they were saying, are we sure that we catch the agency staff testing when we test care homes, because they thought they might be missed out. I'm sure they would actually be done by the care home when they came in for their work, surely. Is that how it works? So they don't sort of go to one care home, they had their test last week, they don't get tested. They go to the next care home who haven't yet tested, then they don't get tested. So that's the sort of dilemma I think they had. I wasn't quite sure how they catch that.
So that it's best to describe it actually the way that we do it at the moment. So at the moment, I see a return every week from our care homes and PCC, and it says how long it's taken a test to come back. So we do whole care home testing every month for residents and every week for staff. And then we get those results back, and so we monitor how quickly or slowly it takes to get those results back. And there's 3 columns to that. There's resident testing, staff testing, and agency testing. So every home tests those people who are working for it, whether they be from an agency or from or on their permanent staff. So you're absolutely right. If you're going to work in a care home and you're an agency worker, you will receive a test in line with all the other staff in that care home. It's worth reflecting, just to add a little bit of context, that we also have, as part of the Infection Prevention and Control Grant, Wave 2, which was issued under the Adult Social Care Winter Plan, that there is a particular interest in restricting movement of staff between care homes, and so not wanting to see agency workers that work in multiple places, because it's considered nationally that that's a significant risk. There's also currently, as of last Friday, a consultation out with the sector as to whether that should be regulated for, so that providers would be penalised if somebody is working somewhere else 14 days before they start working in their particular care home. I don't really want to comment on that because I haven't really absorbed the detail of that, but that's relevant to your question, I think.
Okay, thank
you.
A
couple of questions about figures. The numbers shielding and the numbers of people with disability we're supporting, are you able to share those figures with us? Because it gives a sense of the scale of the work and support we're giving, because obviously shielding, I imagine, is a pretty large number. People with learning disabilities is probably quite a relatively small number. But the shielding is obviously a new thing we've been asked to do, and possibly involves quite a bit of work. So having the numbers might be helpful to get a sense of the workload. I don't know if you're able to share those at all.
I can come back with them. I think it's just worth clarifying, is that the total number of people with learning disabilities that we're working with?
Well, that's one category, yes, learning disabilities who we're helping us bring, and then there's the group of shielding, because some are not. What we call shielding, I know of someone I know who has a heart condition, I think was categorised as shielding. So that's of course potentially quite a large number.
We can do, so I can come back to the committee with the numbers of people clinically extremely vulnerable stroke shielding and the numbers of people we care for with learning disability, and I'll make sure I do that.
You'll be pleased to know this is my last question, which is the DOLS figures. It says application. Does that mean though all those are approved, or are approvals a different figure?
Approvals are a different figure. So an application is an application for deprivation of liberty safeguards. So some will be approved because the assessment will be made and it will be seen that, yeah, absolutely, that's the right thing for the person and that's in their best interests. And then some will be declined and some will be withdrawn. So of those applications, we'll then see a certain number that go through and a certain number that don't.
Is it possible to share the approved ones as well, because it gives a bit of a context? The number of applications, number of approvals each year might be helpful. I certainly would find it useful if that's okay.
Yeah, I can do that.
Right, well, you'll be grateful to know that's the end of my question.
Thank you very much, Councillor Heaney. If you just mute your mic, please, because I keep hearing voices in the background from somebody. I'm not sure it's from a councillor or if it's from officers, but if we could just remind everybody to switch their mics off, please, and obviously switch them on when they're talking. So Councillor Steve Weems, please, any questions from the report, please, members? Don't forget we're here for the report that the officer has given to us. So Councillor Steve Weems, please.
Thank you, Mr. Chairman. You'll be pleased to hear the questions I have. There's only 3 of them. 2 are fairly short, and 1 is actually to you rather than to Andy. But the first is in respect of PPE. During the first wave, obviously, there was a big media storm about the lack of PPE. Did we, I used the term we, city council, care homes, etc. in this city, did anybody at any point run out of PPE, or were they just low on PPE?
Mr. Biddle?
Thank you, Chair. No, nobody ran out that we were aware of, and given the close contact that we had and the amount of publicity we put into the stock of PPE that we held, we also monitored it on I think it was a twice weekly basis. We got ourselves together a report where we talked to care providers across the city and have a number of things that we talked to them about. And one of those was PPE. So we were approached by some people that got low, as in within 24, 48 hours of running out. We managed to supply them, and the logistics bit, we managed to get it out to them as well. But to my knowledge, nobody went without PPE.
Thank you. I mean, I appreciate, obviously, outset is bound to be difficult for people not always prepared for a pandemic immediately. Next question, Ro, is obviously we're at some stage in a second wave now. Don't know how big it's going to get, or whether it's even going to get any bigger. But past pandemics have had second and even third waves. Are we better prepared? Stupid question maybe, but need to ask it nonetheless. You've obviously learnt from the first wave. Do you feel we're better prepared now for subsequent waves? And is there anything you think we should still need to put in place or could do that would improve matters dramatically?
I think we're in a better place. I think we're in a better place because of the lessons that we learned in wave one. I think in terms of keeping in touch with our providers, we continued that, we didn't end that. I think we also made the decision to keep services stood up this time in terms of respite services for carers, because we saw the strain that developed for people, both in terms of not being able to access residential respite and in terms of not being able to access daycare respite. So I think we've learned that, and that's put us in a better place. I think whether we will be better prepared very much depends on the extent of the second wave. In terms of contingency planning, you can plan so far and you can learn so much from previous incidents. But there's a sort of tipping point, isn't there, I think, where you just don't have the resource to respond. I think what we're seeing at the moment is a lot more positive infections and exposures in care environments in Portsmouth than we saw in the first wave. I think we're seeing the hospital under increasing pressure to be able to manage both with its elective timetable, its normal winter pressures and the pressure from COVID, and that always impacts through into community services. I think at the moment we're okay. We're managing to respond where there's outbreaks. We're managing to talk to people and offer them extra support. We're bringing in, actually I was having a conversation today about getting in some extra training to do some refresher training around infection prevention and control with providers. So if we keep managing to respond, I think we'll be okay and we'll come through the second wave. I think it does depend on the numbers though. As I say, if you get to a certain point, it's really difficult to. I think we've become a lot slicker than we were in wave one. And we've also understood, so I'll give you an example of that. I don't want to talk in generalities. We had some infections in our own care homes at the end of last week. And we had letters out to relatives. We had personal communication out to some relatives, letters out to others, and a notification to our ward councillors and group leaders by Sunday afternoon. So that was a very slick process so that people felt communicated with and understood what was going on, which we wouldn't have necessarily been able to do as quickly in wave one. So yes, better prepared depends on the numbers, I think.
Understandably. Yes, understandably. Thank you, Andy. Next question, though, arises from what you've said, but is more properly directed at the chairman. You mentioned the chief exec taking on functions and decisions for the CCG. And I know, sorry, this is where I perhaps have privileged information. I am aware that the CCGs across Hampshire, apart from Portsmouth, are merging, and as a consequence, and part of that is because of the integration with Portsmouth City Council and Portsmouth CCG, and NHS England have taken the decision, or the CCG have taken the decision maybe, not to seek merger with the rest of Hampshire for a whole host of logistical and operational reasons. But it does beg the question about the future of this committee, this panel. Obviously, we have a range of councillors from different councils here, all interested in what happens at QA because they have residents who attend here, but nonetheless, they have CCGs for Gosport, they have CCGs for West Hants, East Hants, wherever. What would be the appropriate composition and remit of this panel come next April 1st when all these changes come into place? I don't expect you to have an immediate answer, Mr. Chairman. I just think it's something we as a panel need to consider between now and then.
What I would ask you to do, Councillor, I think is a very, very good, valid point. I would ask you to put that in an email to me, please, so I've got something from you. And I will get back to you with obviously what you're saying and to find out and do some digging. But I'll take on board what you've said.
Thank you.
That's okay. Thank you. Any more questions, Councillor Steve Weems, to Mr. Biddle?
Not present, thank you, Mr. Chairman.
Thank you very much. So the next person I had is Councillor Raffaelli, that's it. And then after that, I've got a Councillor Rosie Rains who's put her hand up, and I've got a AA who wanted to speak, and that is Councillor Arthur Agent. But at the moment, I'll pass over to Councillor Philip Raffaelli.
Very good, Chairman. Thank you. Just as an aside, we have had previous discussions about the different roles of co-opted members from other areas, because what this committee covers is much wider than simply the Portsmouth CCG, no matter how it's configured. So I look forward to a debate on that, but certainly from where I'm sitting just now, I think there's a very useful function from the co-opted members' boroughs' perspective. Okay, to turn to my questions on the report, Chairman, inevitably a number of the aspects have been touched on, but there's three very brief ones, really. We understand, and Andy's already talked about some of the difficulties, particularly at the beginning, and how well they've responded. Does he have any access to, in terms of loss of clients, bereavement rates, how we compare in this area with the wider Hampshire and with England overall? That's my first question.
Mr. Biddle.
Thank you, Chair. My memory from looking at comparators is that Portsmouth had a relatively low rate of infection in terms of those people that were positive for COVID-19. I guess that's got to be seen in the context of relatively limited testing at the time. And in answer to an earlier question, as I explained, if you don't test people, you don't know if they're COVID positive. You can go on symptomatic, but until you've got to test it, you can't confirm it. So a relatively low rate of infection. Nationally, my memory is that there was something like 18,500 deaths were attributed to C19 in care homes. I think our rates were relatively low. I wouldn't like to say they were low, because I think one death is an absolute tragedy, but I think they were relatively low comparatively. I can probably get those figures for you. They're not necessarily my bag, if you like, but one of our colleagues, public health statistician colleagues, could probably put those in some context, if that would be helpful.
Thank you. It would be. I absolutely take that within a context of how much your exposure rates were, which is the big unknown, but nonetheless comparative death rates would be of interest, I think, to everybody. You mentioned earlier that there's increasing pressure on the hospital. I just wondered if that is in any way translating to pressure onto yourselves for people to be discharged before you're entirely comfortable and ready, or are you satisfied you can almost choose the time of the discharges for these people?
Well, the figure that we go on is something called the MFFD, Medically Fit for Discharge list, that's compiled between ourselves, between Solent NHS Trust and between Portsmouth Hospital University Trust. And so if we've got someone coming out or on that list who we think was unwell or wasn't ready to, then we'd have that conversation internally first. What tends to happen is if we're saying we don't think this person's okay, then there's a review of that person's health and there's an either yes or a no to that. I'm not aware of any cases recently that have been brought to my attention where someone came out before they were ready, where there was a significant risk. It's fair to say that we've seen a real step change in what we call discharge to assess. We've seen a lot more people coming out in a shorter period of time, which is a good thing for the hospital. And if we've got an environment for people to come to so they can make a decision outside of an acute bed, that's a really good thing for them as well. But I'm not aware that we've had any major incidents lately where someone has come out who wasn't ready. There's always a discussion. If we're not sure, if we're uncomfortable, we'd always have a discussion with our colleagues.
I think that's, I obviously understand the terminology you're using. But what I'm specifically asking is, clearly from a hospital's perspective, all of these people are MMFD and are ready to get out, but your part of the discharge to assess in normal time was to get them out as soon as they're at the MFFD plateau, irrespective of their wider care, and to do that a step down assessment, if you like. My real question to you is, and you might have answered it, is that are you sometimes having pressure put on you to take people who you're not necessarily ready to accommodate just because the hospital is happy they've reached the MFFD threshold? I think you're saying that's no longer a pressure on you, or at least if it is, you could have a sensible discussion.
No, I think so. Yeah, I take the point and I take the nuance to it. I think when we haven't got somewhere for someone to go, that is a real pressure. That doesn't often happen. We do see some delays because people are all individuals and they have very different circumstances. For instance, the Gun Wharf unit that I was referring to earlier is 20 beds. They're full. They were full this morning when I spoke to one of my colleagues. Now they'll turn over because people have different times of moving on. So there will be pressure because we'll be informed very clearly that there are people waiting in hospital who no longer need hospital care. But we are usually able in Portsmouth to accommodate people either in a bedded option or indeed in a domiciliary care or a reablement option. Does that answer it a bit?
My concern, of course, is as we move into winter, although flu looks to be relatively low this year, if we do get the additional pressures of COVID upon flu and others, that I can see that pressure increasing, and it's going to be a very difficult balance, and there's a robustness from your side needed potentially. But thank you for that. Then the final point is you do mention, and you alluded in some of your early answers about the testing regime as being a routine regime catching staff and patients and the rest. Is there a more reactive capacity and capability you have that if you feel that there's a particular issue arising that you can direct testing resources to do focused interventions in contact tracing? Thank you.
Mr. Biddle.
Thank you, Chair. Yes, so we do whole care home testing, which is our standard, if you like, and that's staff every week. And we do pick up a lot of previously asymptomatic staff, well, a lot. We pick up some previously asymptomatic staff through that route. We also, through colleagues at Portsmouth Hospitals Trust, are enabled to access their lab testing, so we can get some of our staff up there that day and get a test result back very quickly if we need to. We also, in common with other citizens of Portsmouth, our staff will access the local testing sites as and when they need to. And there is a facility through Hampshire and Isle of Wight region whereby we can get testing if we are unable to get testing by other routes. If it's an urgent case, then we can get testing via the regional test kit unit, if you like. So testing is much more prolific than it was. We still see, in terms of our whole care home testing, some delays in returns, but they are reducing at a rapid rate. I think when I last reported on them to our gold in PCC, we saw about 10% of resident tests took more than 5 days to come back, and about 6% of staff tests took more than 5 days to come back, which is a massive improvement on where we were.
Thank you, Mr. Biddle. Councillor, can I move on? Have you got another final question?
No, that was perfect. Thank you very much. Thank you, Mr.
Thank you very much, Councillor. And we've got two more members wishing to ask some questions. Councillor Rosie Rains, please, who's from Havant Borough Council. Councillor.
Good afternoon. Thank you, Chair, and thank you, Andy. Very helpful report. You did mention earlier on 6.2 about the impact of clients. My question, according to the report, between 28 and 30% of the staff were absent. Did that have an impact on the care for the patients that they were dealing with?
Mr. Biddle.
Thank you, Chair. No, Essentially, that was in PCC care homes. That was a combination of people who were clinically extremely vulnerable, so shielding, and a combination of people that were clinically vulnerable, so the not the shielding population, but were socially distancing. So what we did was we overstaffed, in effect. Now we used agency staff. We also, because we closed several services in the council to focus on critical services only, we redeployed staff into ancillary roles to free up our other staff to carry on. So whilst we were under pressure, I think it's absolutely fair to say the care that we were able to maintain was of a standard that we found acceptable, and we were able to get extra staff in there when we needed to. We were very fortunate.
Lovely. Thank you very much. Thank you. No, I had another question at 6.4 about how the staff and clients coped at Harry Sopnick House, but I think you've actually answered that one, so thank you.
My pleasure.
Thank you very much, Councillor, for your question. I've got one other councillor who wishes to ask a question. Councillor Arthur Agent, please. Agent, sorry.
Semi-precious, Chairman. Agate will do.
Agate, sorry, Councillor.
Yeah. Chairman, it's not so much a question for Andy, more a reply to Steve regarding this committee. If you go on and talk to either Jane or Anna at Democratic Services, they'll give you the contact for both Southampton and Sussex and all the others surrounding the area. So I don't see any reason why the makeup of this committee should change. Thank you, Chairman.
Thank you very much. Thank you for that. Councillor Steve Weems, did you want to just quickly get back on that? Because obviously we're not here for those sort of questions, but
no, indeed. Thank you, Chairman.
Yeah.
I wasn't trying to exclude anybody. I just was trying to make sure that, people weren't asked to come along who didn't feel they should or needed to be here. It's more to make sure that the remit of the committee is appropriate for everybody. I appreciate there's, I've got an appointment at St Richard's in Chichester early next month. So I appreciate that we all represent areas that have patients that come to different hospitals. But all I was seeking to make sure was that we're all happy with what's happening and it's appropriate for each and everybody. That was all.
Thank you very much, Councillor. Hopefully you've made that very clear. Okay then, Councillor. So any other questions to Officer Biddle, I was going to say, Mr. Biddle at all? Any more questions before we move on? No? Okay then, members. So thank you, Mr. Biddle, for coming along this afternoon, and please welcome to stay as long as you like to hear the rest of the debate, I suppose, if you want to, and you're more than welcome. But again, thank you very much for your time this afternoon. Members, thank you. So members, we're going to move on to number 5, which is update from the NHS Southern Health Foundation Trust, and that's pages 21 to 30. And again, just to remember, members, we're asking questions, please, questions on the paper in front of us. So Ron Shields, we've got here. Is that correct?
It is, Chair. Thank you.
Over to you then, Ron.
Thank you, Chair, and good afternoon, members. There are 2 papers within the pack that you have. I'll be brief on both and then be very happy to take any questions that you have. The first is some really good news that we're now we've now received £3.5 million to invest in 2 wards at the Gosport Hospital and to remove the old dormitories that we actually had and to be able to provide single rooms, ensuite rooms for the patients who are using those 2 wards. So we've been trying to upgrade those wards for many, many years. It's great news now that we have that. The programme for doing the work is already underway. Poppy Ward is being done first. It will take 16 weeks, and then we follow on with Rose Ward after that. At the same time, we've been trying to make sure that we manage the impact, we recognise the impact that it has for families and for people who otherwise would be using both of those wards. And there's an ongoing communication with families to make sure that we fully support them. But what we've also done is that we've also enhanced essentially the intensive support team, which is a team working in the community trying to support people to be able to stay at home. And what we've done as the core of that team is we've taken 11 staff who would have been on Poppy ward, and those staff are now working in the community to support the patients who otherwise might have gone to Poppy ward. Where people do need to be admitted, we're managing that within our other bed stock within the county. Obviously, that's an inconvenience and difficult for families in the short term, but we're doing it as rapidly as we can. And the really good news with it is that at long last, local people will be able to have facilities that they should be able to expect in an NHS hospital. So very pleased to have seen that development coming along. The second paper builds on what the Chief Executive just said in relation to COVID, but I'll give it from the perspective of Southern Health in that respect. I mean, the first is obviously collectively, I think there has been an enormous effort from all agencies. We're working very, very well with other NHS organisations, the QA, with Solent, with GPs, and with the council to sustain services as best as we're able to actually sustain normal services as best as we've been able to, and to actually support how we actually keep our staff healthy so that actually they're then able to sustain services. So it's a difficult and it's a challenge in that respect, and as was previously said, the challenge in terms of keeping our own staff fit and healthy in that respect, and maximising the number of staff who are available to care is a real challenge. But so far we've managed to sustain services and to maintain a good quality of care, but we've had to restrict some of the activities, particularly in mental health, in order to sort of be COVID compliant, and also to accommodate the fact that in some cases we've had minimal staffing levels, but always minimal safe staffing levels. So in terms of where we are at the moment, we currently have 25 patients across our beds, across the sort of wards, who are positive with COVID. We have 46 in the trust as a whole. That's a lower number than colleagues at the QA will be managing, but working with the QA and being able to make sure that actually patients are able to move through is one of the key things that we've been trying to do. So working with the QA, with GPs, but also particularly working with the council, the work that's been done, for example, in trying to actually get additional beds open at the Woodcott unit. The plan at the moment is that together, between us as different agencies, we want to get up to a full 80 beds open at the Woodcott unit by the 7th of December. So quite difficulty. The main challenge in that is getting the additional staff that are needed to man the units. But essentially, the work is being done to provide more support in the community teams that enables people not to have to go to hospital, and then to work on the sort of discharge to assess type model to actually bring people back as soon as it's safe to bring them back into community settings and to provide support for them there. But we're creating additional community capacity, both in staffing numbers, but also in terms of bed numbers, working with the council to do that. The situation is moving incredibly quickly. It changes almost by the day, and since the paper was written, things have changed very significantly, even in the last couple of weeks, as members will be aware from the national and the local news. But if I just mention on two strands of that, the testing and where the vaccines are, and what we as a system, a health and care system, are trying to do. On the testing front, the testing regime that's just been described to you in relation to the care homes and so on is similar in some respects to what we've been doing in some of our community NHS premises, where we've been actually looking at and responding in some respects, reacting to where it is that we have outbreaks and actually managing those situations, and on the back of that, bringing in testing of staff and patients who are in those particular services. Where we are now is that nationally and locally we're moving much closer towards more population-based testing. So testing being available when needed on a much larger scale for the general population, but in particular, the part that actually is where we are focused at the moment is actually on testing of staff. And as of this week, and it's literally as of this week, we started to get information about it on Friday night, and we're receiving more information during the course of this week. We're moving closer to a position where we will be able to test all NHS and care staff routinely, probably on a twice weekly basis. And that literally is something which the logistics of which are being worked on as we speak. So that's a positive position in being able to then localize outbreaks, being able to respond quickly, and being able to then sort of prevent the spread. But at the same time then, as you've seen in Liverpool, the population approach in that respect is what's also being worked on, and that's been underpinned by the increased capacity that's emerging in the test and trace system. In relation to the vaccines, I mean, that has changed literally by the days in the course of the last week, and you're probably as much up to date on that as we are at this stage. But where we are as a trust is that the announcements last week in relation to the Pfizer vaccine, the follow-on a couple of days later with the American one, and indeed yesterday and today the discussions then about the Oxford AstraZeneca vaccine. All of those vaccines are progressing much quicker than had been anticipated, but none of them yet are actually through the health checks, through the safety checks that need to be done, and haven't been licensed. But there's huge expectation and optimism that that will be the case. And at the moment, what the NHS is doing is really going through a huge logistical exercise in conjunction with our local authority partners to enable us to be able to provide the vaccine for the population, for the most, it'll be in a tiered approach for the most vulnerable members of the community first, and at the same time to vaccinate health and care staff. But at this point in time, as the vaccines are not yet licensed, then obviously there's a little way to go in that respect. Once there is then confidence and clinicians are confident in the not just the efficacy of the vaccines, but the safety of the vaccines, then those programs of large-scale vaccination will be taking place. But the logistics for that are already being worked through. So the NHS is working through how it would vaccinate those who are most at risk in the community, and also how we will do that for all of our staff. So that is, as I say, changing by the day. But what I would say is that the lessons that have been learned from phase one, we have learned a lot in terms of phase one, and indeed, as you've already discussed this afternoon, it is making us, we are managing phase two better in that respect, but it still remains a very, very significant challenge for us. Thank you.
Thank you very much, Mr. Shields. Members, are there any questions you want to ask on the report? I've got Councillor Philip Riffel to ask a question to Mr. Shields. Could you switch your microphone on, Councillor? Sorry, couldn't hear you. That's it.
Sorry, Chairman, if it wasn't responding to the button control. First of all, thank you for your report, and thank you very much for all the work that Southern Health Foundation Trust are doing. I think you've been one of the leaders in this area now. It's something you should all be proud of. Speaking from a Gosport perspective, we're of course delighted with the money that's going into Poppy and Rose Ward, and I understand what you're saying, that the whole schedule's on time. I do have one question though. From what you're saying, I think I now understand that the intensive support team is a transient measure during the work on the two wards. Is that the case? Because that's such a potentially valuable asset, and if we can keep people with these issues in their own home safely and successfully, wouldn't that just be wonderful, as well as having inpatient facilities? Thank you.
Absolutely. Absolutely agree with you, Councillor, in that respect. Setting the team up and doing it literally as we're moving through, we've used a core of the staff from Poppy Ward first, but what I would hope for is that we would continue to have that approach, because as you say, that is actually what we're trying to do, is to support people and to enable them not to have to go to hospital. So what we're seeing across the whole system is that there is significant investment going into the community, into this sort of service, and my expectation would be that it should continue even when we get Poppy Ward reopened, because that's the way in which we actually ultimately avoid people having to go to the QA, for example.
Councillor, did you want to come back?
No, that's exactly the answer I was hoping to get. Yeah, well done, and thank you again.
Thank you.
Thank you, Councillor. Thank you, Mr. Shields. We got Councillor Arthur Agate. I said it right this time. Councillor, would you like to ask your question, please, to Mr. Shields? There we are. Got a clap. Could you put your mic on, please? There.
Oh, I've got to put my mic on as well.
Yes, we can hear you. That's good.
Okay, fine. Thank you, Chairman. Ron, I've got your overview of service changes, and the one I'm looking at is the fifth item on page 25. Your risk assessment, your overall 94%. Now, this report is a month old, so presumably that should be near completion by now, I would have thought.
Okay. It varies slightly. So, for example, the staff who we know who are most vulnerable, actually we had 100% for them, and we had 90% or 94% for the whole of our workforce. That's changed slightly, and we've actually had some 9 or 10 people who are within vulnerable categories start, so they're currently going through that assessment, but it's still in the high 90s rather than 100%, and that will change as staff come and go. We need to then keep assessing and keep making sure that we then put in place with them and in agreement with them the right protective arrangements.
Councillor,
thank you. To follow on from that, on the next page, 26, 1,300 staff had to self-isolate, more than 500 on sickness. Presumably that's altered, I would hope, quite considerably by now.
It fluctuates by the day, Councillor, obviously, in that respect, and the quarantine periods in that respect, the 14-day quarantine period has been a real challenge in that respect. The latest position that I understand, which was as of Monday this week, was that we had some 70 staff absent. This is for the trust as a whole, some 70 staff absent, of whom 20 were positive in terms of COVID. So there are 50 others who are actually isolating for periods of up to 14 days.
Quite a good change on that initial report then.
Well, I think it's that the report reflects the aggregation essentially, because what you have is more and more people sort of coming through. That will be the total numbers. We have a workforce of getting on for 6,000 people. So, you know, in that respect, some of those people may have been infected twice, for example, or had to sort of isolate twice. Others will be for a 14-day period. So it's a cumulative figure, which is what accounts for the difference. But
okay.
As I say, the daily position as of Monday was 70 staff absent from work, with 20 of those who had tested positive.
Cool. The other thing is you made a note of immunisation for children, and that you've got to do a catch-up. How's that progressing?
I haven't got the numbers today, Councillor, but I did hear earlier in the week the immunisation programme is going very well with youngsters. It's worked incredibly well. We've more work to do with some of the youngsters with special needs, where at the moment there's some difficulty that actually, for various reasons, that the parents or the schools are not so receptive to having sort of the immunisations undertaken, but discussions are taking place, and we're quite positive that actually that is improving and changing. So the picture is a good one in terms of the immunisations that have been undertaken. I would certainly be happy to provide figures to the panel for the next meeting if you would wish.
Sounds like a good idea to me. Thank you very much. That's me, Chairman.
Thank you very much. Mr. Shields, yes, if you could provide those figures to us for the next meeting, that would be most helpful to us all. Councillors, any more questions for Ron Shields, please? Mr. Shields at all before we move on? No? Councillor Agate, would you put your hand down, please? Thank you very much.
Hang on, I've got to find it first.
That's all right. Thank you very much. And switch your mic off, Councillor. Thank you very much. Okay then, Mr. Shields, thank you very much. And members, just to note and update that, but I think Mr. Shields is coming back to us in a few minutes, I think. But thank you very much, Mr. Shields, for your report. And members, obviously, we're here to note the update, so thank you. So next thing is we're going to number 6, which is update from Southern Central Ambulance Services. So this is to invite Tracy to give her report over.
Thank you very much. In terms of the South Central Ambulance update, I was with you last quite some months ago, so I'll just briefly talk through some developments we've had, where we are in terms of our performance, and obviously some of our challenges, which does include some information around our COVID-19 response. So in terms of developments, we do continue to work across the health and social care sector with our partners, with our aim to provide patients with the right treatment at the right place at the right time, which clearly is not always in the hospital or in a hospital setting. So we're working very hard on alternative and appropriate options for those patients that don't need to be in hospital. We have some of our clinicians embedded in some of the community teams locally, and equally we have partner agencies embedded in our control room. For example, we have a labour line, we have social work colleagues, so they can support the crews on the road from the control room, but they can also intercept some of the calls in the control room and provide advice and support to patients as well from within the control room. And alongside that, we continue to work with alternative options for our patients. We're working closely with primary care colleagues and also with QA Hospital in terms of non-ED locations to support those patients who don't need to go to ED but do need to go to hospital for some other kind of intervention. And we've developed some new technology to help our crews to do that in the form of an app which will direct our crews to what's available in the local area in terms of pathways, how they can access those alternatives, what times they're available, etc., etc. And in addition to some of our new pathways, we have taken our COVID opportunity to speed up some pathways that we had been working on previously. For example, the minor injuries and the mental health pathways. We've sped up through COVID to ensure that those patients don't need to be in the hospital or not in the hospital, with a view to carrying on those as standard pathways post-COVID. So some learning that we've taken from the COVID response that we'll be continuing with post-COVID is the current plan. So just in terms of performance, people will note hopefully from the report that year-on-year improvement pretty much across the board for our national response time targets. We have seen a fluctuating demand this year with the COVID. We saw an increase in demand in different areas of the organisation. So, for example, at the beginning of COVID, we saw an increase in demand in our 111 service. then an increase in demand in our 999 service, and then some challenges on our PTS service. So the demand has moved around the organisation as COVID has developed, and we're seeing a similar pattern really with wave 2 of COVID, albeit it's not happening quite so quickly. And just to note on the performance information, our conveyance to ED continues to come down, which is one of our primary areas of focus at the moment. Firstly, to make sure the patient gets the right treatment in the right place, but also in support of the hospital, whose ED department is very busy at the best of times. So we continue to focus on not taking patients to ED. Just in terms of challenges, clearly COVID-19 has challenged all of us. As a sector, I think it's brought everybody working more closely together across health and social care. Things are, I think you've heard from colleagues already, things are changing by the day. It was difficult initially to interpret and adopt national guidance at the speed at which it was coming out and changing, but that for us has settled now. We're comfortable that our staff are safe in terms of PPE, and we're able to provide our service as best we can. We have got plans in place to enhance our service again if we need to, in terms of an increase in capacity, with agreement for support from our colleagues in the fire service and in the military, which is again some work carried over from wave 1, and that's in place should we need to call upon that, as well as our command structure within SCAS and how we interlink with partners is starting to build up. It's been there since wave 1, but it's been more virtual, and we're now seeing a gradual increase in activity from our command function as well. Just in terms of one of the other challenges, we are challenged with our handing over our patients at the hospital. People will be aware of that from previous things and other reports, no doubt. And that's that through COVID wave 1, we saw some improvement there. I think the hospital were in a better position to manage some of the surge. The demand was down, but we now find ourselves back in a place where our business as usual demand has not dropped off yet, as it did in COVID wave 1, and our COVID demand is starting to increase. So the demand is there, and the hospital is challenged in terms of capacity. So it is difficult for us to offload patients sometimes. And we do lose hours worked there, which is demonstrated in the final graph in the report. And just moving forward, we continue to be concerned about staff absence with COVID. As I say, we have got some mitigation in place with support from other agencies, and we continue going forward with our winter planning, which incorporates COVID as well as other business as usual kind of winter planning. So that's a very quick whistle-stop tour and a brief summary, but happy to take questions.
Thank you very much, Tracy. I've got Councillor Raphael, please. Councillor Raphael, please.
Hello, Tracy. I had been going to ask about the staff, but you covered that in the end. As long as you're comfortable, you have a way ahead, then that's fine. Because your people must have been under a fair amount of stress, and we're grateful for all they've done. I'm also very pleased to see the year-on-year improvements, but you know what I'm going to say next, the level of differentiation for Gosport within the Fairman Gosport numbers is very difficult, and I really would appreciate if you could continue to give us by postcode so we can see whether the people down in the peninsula response times are being met. That would be my first question.
Tracy, would you like to answer that question first of all and give us a time factor when that could happen, please?
Absolutely, I can provide the postcode data. Obviously, it will take me a couple of weeks to pull a report together with the current amount of activity that we've got going on. But absolutely, I can do that. Yeah.
Thank you, Tracy. So within a couple of weeks, then, if you could share that with members, that would be great, Tracy. Thank you. And we're sorry to load you up with more work, but I just think it's quite important. Councillor, do you want to ask?
I appreciate that too. Thank you. Another one's maybe subjective, but we've heard so much about people holding off going to hospital to the very last minute. Is that something that's borne out by your staff? Have you been getting to people later in the course of illnesses or disease or emergencies, or is it all too mixed in for you to be able to have a feel for that one way or another?
Tracy.
Yeah, it's difficult to say where that comes from, because we have seen an increase in acuity, so more poorly patients, but we normally do at this time of year. So it's difficult to say whether that's a normal seasonal increase in acuity or whether that's COVID related. We don't have any data to support either way, to be honest.
Councillor?
No, thank you for that. I've detected a shift in the narrative coming from the higher echelon in the NHS to almost say that people have been keeping away from medical services. I think people were, yes, they were very cautious, but I think, in fact, people often found it harder to get towards medical services, not ambulance services as such. So I just wondered whether there was, from your perspective, a sense, but what you're really saying is there's nothing that really stands out to you that's any different, and I'm very happy with that. If you like, that confirms my feeling that we are where we are, and people, if they need you, they've been calling you. Thank you.
Tracy, did you want to say anything on that?
Absolutely right, and I think that's the case. And with the anecdotal conversations that people can't access primary care, we would normally see the backlash of that, which we've not seen. So to me, that demonstrates that primary care is still doing what it needs to do, albeit people are doing things in a different way. So we're not seeing any additional, which we would normally see if there was an interruption in primary care. So that's positive as well.
Thank you very much, Tracy. Councillor, did you want to come back with any more questions at all?
No, we're all agreeing with each other. Thank you.
Okay, thank you very much. Councillors, any more questions to Tracy Redmond, please, before? Yes, sorry. Councillor Agat, please. Let's hear from you. Switch your mic on, sir. That's it. Well done.
Thank you, Chairman. Tracy, I must thank your ambulance teams for giving this out in the sticks here some excitement. I know that whoever's in the control room that takes the 999 calls may not be that au fait with a particular medical emergency, but when your team turns up with an ambulance, 2 cars, and they all start to get into HASCEM suits, the locals get worried. The simple thing was that it really didn't need it, but it was the person at the other end of the 999 call who didn't comprehend what the problem was or the situation surrounding it. PSP is not a particularly well-known problem, but it does cause choking. And we're about twice a month. They turn up to my next door neighbour, get the machine out, clear a throat out, and this is after my next door neighbour's already tried with his own kit. But to turn up mob-handed and change into the HASCEM suits certainly caused a stir around here. I don't know how you would get round that, but we should look forward to the next time. Thank you.
Thank you, Councillor. Tracy, did you want to answer that? I suppose it's safety of the crew, I expect, is what you're going to say. But Tracy, I'll leave it to the professional. Would you like to answer that?
Yeah, absolutely. We've got two standard levels of personal protective equipment. One is for all of our patients, which is a mask and an apron. And gloves, and the other, which is the enhanced level, which sounds like the one that you saw, which is for procedures where there may be aerosol generated, and suction for us is one of those. So they were following the national guidance of enhanced PPE where there might be a need for suction. So next time they come will be the same.
Thank you very much, Tracy. Councillor, did you want to come back on that or not? He's laughing there. No, he's fine.
Well, yeah, it's the PSP does not require HAZChem suits, but it does require a little bit of understanding on the person at the other end of the telephone. But not to worry. It's just the amount of ambulance, 2 cars, the HAZChem suits have to be taken off and disposed of in another box, which goes into one of the other cars and gets taken away. And it seems an awful lot of waste over such what is effectively just a simple matter.
I'm happy to, if it's helpful, I'm happy to, if you can send me the address, we may be able to, I'll look at the detail.
Thank you, Tracy. I know from experience when I was the former Lord Mayor of Portsmouth, I came up to the central there and watched all the operations on the 2 floors there and watching the staff taking the calls, and it was certainly an eye-opener for me. So, and the training that goes on there, I mean, I'm sure I speak on behalf of all members here as to thank you for all of you for what you're doing out there with this terrible pandemic. So thank you certainly on behalf of me as chair, and I'm sure everybody else for what you're doing, and please pass that on to everybody else. Members, any more questions to Tracy before we move on? No? Okay then, so members, to note the update, and again thank you very much, Tracy, for all your help, and we'll see you again. Thank you, and be safe please. Thank you. Okay, members, so we move on to number 7, which is update from Portsmouth Hospital Trust, which is pages 35 to 42. Lisa, have we got anybody here to be able to introduce those papers at all?
Yes, it looks like Penny has joined us now, so we should be, yeah.
Lovely. Penny Emirates, then, I think I pronounced that correct. Penny, would you like to introduce your report, please? Thank you very much.
Thank you, Chair. Yes, thank you. There's a couple of things that I'd just like to draw out from the report, and then of course happy to take questions. I'm going to take it out of order from the paper and start with an update on building better emergency care, and then I'll come back to our current context in terms of COVID, although joining for some of my colleagues' updates, you've heard quite a lot about that, so I can add our own local context. So in terms of building better emergency care, we shared a stakeholder briefing in September following confirmation that our strategic outline case had been approved by the Secretary of State for Health and Social Care, Matt Hancock, which is fantastic news for us because it means we're able to continue to make progress towards a new department. The capital investment provides us with an opportunity to both have a new department but also redesign emergency care to make sure that we can put in place timely assessment and care of all of our patients requiring emergency care so that we minimise handovers, duplications and delays for our patients. The programme is working across health and care partners to tackle some of the long-standing issues that you will have heard about here and to which Tracy has just referred. I have talked here previously about the 111 First programme, which is an example of where we're trying to make improvements in urgent and emergency care in advance of even this new estate coming on board. So just to give you a bit of an update in terms of what we've done since that strategic outline case was approved, we have appointed a preferred supply chain partner, Integrated Health Partners. So we've got expertise on board with us now to support with the design and build of the new site. We've also identified the preferred site at QA that takes into account space requirements, clinical adjacencies into the existing building, and thinking about how the phasing and disruption on the site might work to make sure that we're getting value for money so that we're investing the majority of the money in the clinical estate, as opposed to having to move things around the estate here. And we've identified the East car park, which is the current staff car park, or a portion of the East car park will be where that's likely to be built. We've also, off the back of that, updated the timelines, and we are working towards submitting the next stage of the business case, so the outline business case, early next calendar year, hoping to open to patients later on in 2024. So the capital investment helps us to enhance our current provision of services. So it doesn't change the nature or location of those services, but it does give us that opportunity to redesign in the way that I've described. We intend to carry out engagement over the coming months to inform that clinical model, the design principles for the building, to make sure that they're underpinning in that new facility. In the later stages, we'll have a wide-ranging engagement to inform the detailed design and make sure that we're speaking to patients, public, staff, obviously committee members, our partner organisations and the wider community to make sure that's reflective of needs. Any patient car parking impacted by this development will be replaced on the hospital site, and a traffic solution will be included as part of the design. So we're currently developing a package of measures to help alleviate traffic congestion and manage demand for parking and promote sustainable travel around our site. And in fact, some of the changes that have happened during COVID in terms of being able to promote some remote access to services will also help with that. We continue to work closely with the City Council and the University of Portsmouth on our sustainability initiatives, and very happy to provide further updates in the future in relation to any of that. So that's the Building Better Emergency Care. If I come on and just briefly talk to you about where we are in terms of COVID, I'm sure my colleagues will have described that the prevalence in the city continues to increase, and the rate of infection here is above the national average. So the national average is 274 cases per 100,000 population. In Portsmouth, we're at 312, so quite a significant increase. And you can see that the rate of admission to our hospital is in line with that rate in increasing prevalence in the city and obviously beyond. What we saw in the northwest of England was that cases moved through the population from young adults to older adults and then into the most elderly. And then, of course, the case mix in hospitals changed in line with that movement through the population. And that is reflected now in terms of where we are. And we're currently caring for more than 130 patients with the virus at this point in time. Of course, alongside managing that and all of the infection control measures that go with that, we are maintaining access to urgent, elective and cancer services, as well as recovering activity for our routine work and restoring the non-COVID health services. So in relation to the question earlier about access to some of those services, happy to talk about that. Tracy's already referred to the fact that the hospital is currently very busy as we try to balance each of those priorities. So our COVID, our non-COVID patients, and then restoring the services that were there that we need to make sure we're recovering from the first wave. Just in terms of whether or how the national restrictions are impacting on what we're seeing. So we're obviously 2 weeks into the further period of restricted movement. We do expect that our admissions will continue to increase for a short period still before we see the impact from those restrictions. So we've got an increasing admission rate. We expect that to continue for a little time before we see the impact. So of course we're continuing to encourage our staff and patients to adhere to all of the national guidance and of course full utilisation of PPE where that's appropriate for our staff. Thank you, Chair.
Thank you very much, Penny. I've got two members who wishes to ask some questions again about the report, and that's Councillor Agate, please, first of all.
Thank you, Chair. Put my hand down. It's regarding the new build.
Yeah.
Will your triage continue in the current location once the new build's up and running, or will you be using that for some other purpose?
In terms of where the existing emergency department is, do you mean?
Yes.
So the front door to the emergency department will move in line with the new building. But in terms of what I spoke about last time around the 111 first model and the utilisation of that type of space, we will continue with those types of processes, but it will be through the new building.
Thank
Councillor,
you.
Did you have a follow question at all, Councillor? No. Okay, that's a no then. Councillor David Keast is next, please.
Thank you, Chairman. We heard about the recent increase in numbers, which is quite concerning in Portsmouth, particularly as they did so well during the first phase. And I've personally know a couple of people recently who have contracted COVID, and in both cases, there are student connections. How much do you contribute the increase in Portsmouth to the return of the very large number of students that use the city's university?
Penny.
Thank you. So you're right, we are seeing an increase in cases and an increase in admissions. The link between cases and admissions tends to be as you move through that older population, as I described. So our more vulnerable communities tend to be those who then end up with the admission to hospital. So the way that we noticed the pattern through the Northwest was as I described, in terms of starting in the younger population and then moving through. I can't say whether there's a direct cause and effect there, because of course that one of the differences between this wave now and what we saw before is that we have got an increase in testing available, so we are able to identify much earlier on where people may have COVID, even where they're not displaying symptoms. So I think you heard my colleagues talk earlier about the fact that we are identifying people who have the virus who aren't showing any symptoms of that.
Did you want to go back, Councillor, with a follow-up question?
Yes, I understand what she said. I mean, I think most of us have seen and read about some of the irresponsible students who have held parties and in one or two cases actually been fined. And it seems to have the actual COVID in Portsmouth on the second phase seems to have started with the students and then gone to the older population, which is why now you're getting the older population becoming infected more. Would that be a fair summary?
So I wouldn't directly attribute it to the students. I was talking about the link between the prevalence and then the admissions into hospitals, because of course the admissions into hospital tend to be in the older population, not exclusively, but that tends to be the point at which we see the increase in admissions to hospital.
And a second question, if I may, Chairman,
yes, of course,
is that, and this is sort of in abstract as an administration thing. At the moment, QA is doing a lot of consultations on the phone. The consultants are bringing people up and just talking to them on the phone rather than have appointments at the hospital. One of the things that you have done at QA is that you block your own phone number. So if a patient will not accept an unidentified call, and I'm one of those people, because your number is blocked, when that consultant rings me, he can't get hold of me because my phone won't accept it. Could I suggest at QA you actually unblock your phone numbers? I can see no reason why you should hide them, so that this doesn't happen in future.
Penny, did you want to come back on that one?
Yeah, so I don't have the technical detail related to how the telephone system working, but if you let me take that away, Councillor, I'll have a look at how that works at the current time.
Well, it's basically your number's hidden, so if you make a call, the person at the other end can't see that it's you that's calling.
Okay.
That's basically it. Thank you.
Okay, Penny, do you know when you can get back to us on that issue that Councillor Geese has got with the telephone numbers? How long?
Before the next meeting, I'll make sure that we've come back in terms of how that's working.
Thank you very much. Councillor, did you want any more questions to Penny at all before I move on to the next councillor? No. Okay, thank you. Councillor Philip Raphael, please. You're next.
Thank you. Two questions, if I may, one relating to COVID and one relating to same-day emergency access. With respect to COVID, what have been the nosocomial rates for COVID within the hospital? And then the second one is, I heard you say you've got 130 plus patients, but how many are there in intensive care? And what's your sort of maximum? What's your head gap?
Okay, thank you. So in terms of infection, I will come back to you with the exact numbers, Councillor, but we have had some examples of where we've had infection within the hospital. We put in place stringent infection control processes around that, and we manage those infections within the area where they occur. And of course, we apply our testing regime to that to make sure that we are identifying whether or not that spread has gone further. So we identify an index case and then look to see whether there are any other contacts potentially at risk, and then isolate those patients as well. So I'll come back to you with the exact detail, but that's the way in which we go about managing that situation. In terms of our capacity, so our critical care capacity is obviously used for both our COVID patients and our non-COVID patients, particularly supporting our elective care. As a baseline, we have access to up to 24 critical care beds, and then we escalate beyond that. So we are already in escalation areas in terms of the numbers of patients that we are caring for in our intensive treatment unit at the moment.
Thank you, Penny. Obviously, I'll come back to Councillor in a second, just to remind Penny two things there so far to come back with us. Councillor, would you like to come back for the next question?
Yeah, interesting statement about the intensive care, because it's still early days. Fingers crossed that there's more space. Yeah, the same-day emergency care pathway, there's pluses and minuses to continuing to run a pilot during a pandemic. In some ways, it'll be helping the system. In some ways, it might make it more difficult. What I'm slightly nervous of is it seems to be quite good from a system perspective. What I'm not so sure about, it may be just lack of visibility on what data has been collected and how it's been followed through, is how satisfactory it is for patients. I would imagine that those who are given an appointment that day and arrive and see the appropriate consultant straight off, it's wonderful. The bunch I'm worried about are the ones who are told, no, you're not suitable for same-day emergency care treatment, and get sent off to another provider. And I wonder how that group is followed up, and including not just their patient pathway and their perspective on it, but how many of them end up ultimately coming back to ED, and on reflection that might have been the correct location from the beginning. So it's how's the trial working? I wouldn't want you to make any final decisions till we're through all of this and we can see all of the data. Is what I'm really getting at, Penny.
Yeah, sure. Okay, so thank you. You're referring to the work that we're doing around 111 first and the access to urgent care. So I think you may be aware that it was we were one of two initially early adopters for what is a national approach to looking at urgent care. So I absolutely accept what you're saying in terms of the pros and cons of doing it when we're in an uncertain context. But indeed, the driver one of the drivers for doing it was to try to minimise the risk of infection for patients waiting in waiting areas where perhaps they didn't have a need to do so. So I think there is a clear rationale for why now might be a good time to do that. And you reference, of course, the benefit for the system But I think the wider benefit for the patient in terms of making sure that we get that patient to the place that best suits their need. Effectively, it provides a patient with one route through which we can support navigation to the right place. So whether it be booking an appointment in our emergency department, booking an appointment in one of our same-day emergency care, so bypassing the emergency department and going direct into a specialty, or indeed getting a patient back to their primary care practitioner or into the urgent care treatment centre. So as part of the pilot, you're right, we're running, so there's a national evaluation running that's looking at all of the pilots that are working, and we are also collecting feedback from patients as we go. The feedback that we've had from patients who have come to our emergency department, as you say, is largely positive in terms of the experience. One of the areas where we've had feedback is that actually patients have asked for more information about it in advance of coming to the emergency department so that they know to contact 111 first, so that they don't then come to here and then potentially go somewhere else as a result of that. So we're keeping all of that under review, making sure that we've got patient and staff feedback as part of it. And we've got, we're able to look at data across certainly the urgent treatment centres, the 111 service and the GP clinical assessment service to understand where patients are going. And what we have found is that so not for ambulance patients, and Tracy was describing earlier that our demand in terms of ambulances here is back above what it was pre-COVID, and indeed that we planned for this year. But in terms of impact on patients who are walking into our emergency department, where patients are able to access a GP with access to their notes, we are able to direct them to other areas where their needs may be better met.
Thank you, Penny. Councillor, did you want to go back? I've still got 3 other councillors who want to get in.
I can take a hint, Chair. No, that's fine. Thank you.
Thank you very much. Thank you, Penny, as well. Councillor Steve Weems, please. Councillor Steve Weems.
Thank you, Mr. Chairman. Hi, Penny. I must sort of declare a code of conduct interest here, in as much as A&E is only about 200 yards that way from me. So I noted what you said about ED moving, but I'm conscious that Southwark Hill Road frequently gets queues of cars coming to outpatient clinics anyway because of difficulty of parking on site. And you're saying you're going to build a new ED department on one of the patient car parks. So my concern is, for the interim, at least until the ED is built and you've got another car park built, that patients are going to miss their appointments or be late for their appointments because of the difficulties they're already having accessing the QA site. People are already doing that now before you even start the work. So I think, I'm sure you probably haven't got a ready-made answer for this because it's all in the planning. But I think I'm making the point to you now so that you can plan for it. Is that a reasonable thing for me to have done?
So it is absolutely reasonable to identify the challenges that we have already in terms of access to the site. So a travel and transport plan is a core part of, well, it's an underpinning part really of all of the changes that will be ongoing over the next kind of 5 years on the estate. So absolutely, it's a priority that we are able to minimise that disruption. And so the new emergency department is on a staff car park. There will be a kind of a domino effect between patient and staff parking with the additional beds as well. But we will ensure that any patient parking affected is replaced on site. We have to look more broadly at access to the site and access to parking for both patients and staff as part of this process. So you're absolutely right to raise it as a point, but it is an underpinning part of our planning around all of this.
Councillor Weems.
Yeah, no, it's just that I think there may be enough parking perhaps now, but the difficulty is people accessing it. While people are manoeuvring to get into the parking space, then you get the queues backing up then. And I think it's the flow around the site that's the issue as much as the parking.
Yes.
Okay, thank you very much. Any more questions to the offer to the Penny at all, Councillor?
No, thank you.
No, thank you very much. I've got Councillor Leo Madden next, please. Councillor Leo Madden.
Thank you, Chair. Good afternoon, Penny.
Hello.
Congratulations on getting the strategic case, or the strategic outline case, approved. We know that things like that can take years, and I look forward to this new building being in place whenever it's going to be. But I just want to follow on a little bit of what Councillor Weems has said in relation to parking, because it's always it's a problem everywhere. But not currently, not with a build or whatever, because I think you've resolved that. I'm just wondering that after COVID and after all the problems that we have at the minute, whether you anticipate there being enough parking for patients and staff. Because the number of times I've been up and got a bus back, I noticed in the car park really, really full, the staff car park itself. Do you see a situation where there'll be more remote working because of the experience that we had this time, and therefore you will need less, and people maybe using public transport better, you will see less need for staff and public parking? That's question one.
Thank you. So there's a couple of things in there, both about how patients are accessing our services, but equally how our staff are working. And you're absolutely right. We have seen changes in both of those things. So outpatient appointments, for example, and we've already referenced recognising the difficulties that were described, the intention where possible to mean that patients don't have to travel to the site if they don't need to, and that those can happen virtually, whether that be through telephone or video consultation. So we anticipate there may be an impact from that in terms of patient parking, and that will be part of what we need to look at in terms of our planning. From a staff perspective, of course, many of our staff have to continue to travel to the site every day to do the jobs that they are doing, but we do have some staff who traditionally would have travelled every day, who are now able to do some, at least, of their work from home. So you're right, there's some work for us to do to understand what we think that overall impact might be. Just in terms of, so we haven't reached any conclusions about whether the overall quantum is right yet, but all of those things that you've described are being taken into account. Just in terms of the staff car parking, of course, that's a combination of both parking on site, but also the park and ride service that we have available from Fort Southwark down to the site through that park and ride piece as well. So we need to take all of those things into account as part of the planning.
Councillor Madden.
Yeah, thanks for that. I mean, we'll see all the plans or whatever as time goes on. I was just wondering what was in that and whether we were, you, like the City Council, hopefully are looking forward to the future and people using less cars. When we say people using less cars, Penny, of course, we mean everybody else and not ourselves. So that's always the problem with it, isn't it? Could I just go back in the report itself? You're absolutely right. In July, the Chief Executive of NHS talked about getting back to near normal. And maybe I'll merge my two questions into this, if that's okay, because it's to do with services that you provide. I am particularly concerned about people with cancer and whether it's had any negative effect on what we do with people with cancer. And I also read today that there's a possibility of a probability of an outbreak of bird flu locally. And are you prepared for that? Thanks, Penny.
Okay, thank you. So in terms of access to cancer services in particular, we have managed to maintain our performance against all of the cancer standards, even throughout the first wave. So we did maintain urgent and cancer services throughout, which is really positive. And of course, we continue to encourage all of our patients to access those services. And we've worked with our colleagues in general practice to make sure that that message was getting to our patients, and that's consistent with the national position. One of the things that we also did in terms of informing our return to near normal was to make sure that we were monitoring the levels of activity that we would have normally seen compared to what we were seeing. And what that enabled us to do was to identify whether there were any particular conditions where we weren't seeing the level of demand that we might have anticipated, in order to be able to work with our colleagues across healthcare to ensure we were accessing the patients who, or the patients who required our support were accessing those services. Of course, during the first wave, there was a natural concern from the population about accessing hospital services, but we don't believe now that there is significantly less activity coming through for those types of services, Councillor, that would have the impact that you've described. But of course, the impact will be seen later if in fact there were patients who were holding back accessing services. But we did make sure that we were monitoring those types of expected activity. In terms of your point about flu, so that is always and continues to be, even this year, a core part of our planning for winter. You'll see in the paper we referenced flu vaccination, and our staff flu vaccination rate is now above 70%. So we're doing really well in terms of encouraging our staff to access the flu jab. And yes, we do anticipate that we will need to plan for both flu and COVID infections during the winter, and that will place different demands on our services if that transpires.
Thank you. Councillor Madden, did you have another question before I move on? I've still got two other councillors, okay? Thank you. The next person is Councillor Rains, please. Councillor Rains, please.
Thank you, Chair, and thank you, Penny, for your report. Ironically, I worked at QA 40 years ago in the same department, and it had only just opened, so I'm totally aware that things have changed. However, you state in your paragraph 1.2 that you are ensuring discharge in a timely manner for disabled patients. Sadly, I had to take my own father there 2 weeks ago, who has dementia. And with the visit to St Mary's, as we were advised by 111 first, and then told to come to QA, we were there 10 hours in total. What do you think you would be able to do to make that better? Bearing in mind the department wasn't actually very busy. I was quite concerned for him.
So this was in terms of from the emergency department?
Yeah.
So I think what I was referring to in the report was that the performance of the emergency department is of course affected by a number of things, not only the performance of the department itself, but also what's going on in the rest of the hospital in terms of where we need to access beds for admission. So it was making sure that we don't only focus on a new building as part of the resolution, but that we take the opportunity to look at our systems and processes and pathways of care to make sure that they're as efficient as possible operating within a new department. So clearly, without knowing the details of the case itself, I can only say that even while we wait for the new emergency department, we continue on a daily basis to make sure that we've got improvement activity to make sure that our emergency patients are receiving safe and timely care. And I can only apologise that that wasn't your experience.
Okay, thank you. Just as by the by, we had a meeting last year, pre-COVID, for the Health and Overview Scrutiny panel with Mark Cubban, and he did mention in his comments that he was thinking about a dementia specialised area for people with dementia within the casualty department.
In the emergency department. So we can certainly ensure that that's picked up in our future space planning. So we've got an idea of the sense of scale of the department, but what we're in the process of doing now is determining what each of those areas might
need to be used for. So that's a key part of the engagement activity around where that might best be. Okay, thank you very much. Thank you, Chair. Thank you.
Thank you very much. Just to inform the panel and councillors that Councillor Cartwright has left the meeting about 15 minutes ago. I keep forgetting to say that, so thank you to Councillor Cartwright for him. And I've got one more person at the moment who wanted to speak. It's Councillor Lee Mason. Councillor Lee Mason, please.
Thank you very much. Just really saying that as I declare a bit of an interest as ward councillor, I have had a bit of conversation about the building works and had a look at them. And the letters have gone out to my residents a few days ago, so I've had quite a bit of going back and forward, and we're quite pleased to have the multi-storey car park going in that back as part of the development. I think parking is still very much an issue on the main minds of a lot of the residents around there, so when you get to the next phases, please do think about being generous with the parking.
Penny, did you just want to quickly answer that?
I don't think I have very much more to add in terms of what I said earlier, but thank you.
Councillor Mason, did you have another question at all for Penny? No. Okay, thank you very much, Councillor. Councillor Leo, madam, would you just put your hand down, please, before we get on to the next one, because I might come to you when you don't want to speak. Thank you very much. So thank you very much, Penny. Very popular there, and thank you for everything that you do. I take it no other councillor wishes to ask any questions to Penny? No? All very quiet, so thank you very much, and I think all of us have noted your report, and can we thank you and all the staff for what you do up there at this troublesome time, and wish you all best of health. Thank you very much, Penny.
Thanks very much.
Thank you. So we move on swiftly, members, if we can. Updates for NHS England and dental practices. This is page 43 and 44. Lisa, I don't think we've got anyone for that report, is that correct?
Yes, Chair, that's correct.
Okay then, so we just really have to note that. Is there any people, any councillors want to sort of ask any questions on that, and we can make sure that goes to the people concerned. If you do have any questions on that report, councillors, I think if you could write it into Lisa, and we will get an answer for you, and I think we should get a written response from the people at the dental place. Okay, so if that's okay with members, yeah, everyone happy with that? Okay then.
Like pulling teeth to get somebody there from dental. Jim.
Well, we'll have a go. So as I said, put it in writing, and we'll see if we can get an answer. Members, I'm moving on now. I think that's just about the end of. Sorry, Councillor Keast. Sorry, Councillor Keast, you had something to say.
Thank you, Chair. I waited until the end of the meeting before I raised this, but I don't know if anybody else noted the deliberate mistake. But whilst Tracy Redmond was giving her presentation, I'm sure to make you smile, she referred to flatulating demand rather than fluctuating demand. And I couldn't stop laughing on this.
Well, there we are. Thank you. Yes, well noted, Councillor. Thank you very much. Okay, councillors. So I think it's time to, if everyone's happy, time to pull it to come to an end. It gives me pleasure to thank everybody for this afternoon. Thank all the councillors, thank all the officers and democratic services, and thank the general public and everybody else for this afternoon. It's been very good and very informative, I must say, and I must say the reports have been very, very good and yeah, very detailed as well. So I wish to now call the meeting to an end, and the next meeting that we will meet again is on the 21st of January at 1:30 in the new year. So with that, thank you very much and have a good afternoon. Take care. Bye. Bye.
Thank you, Chairman. Have a good Christmas.
Thank you.
Thank you, Chair. Thank you.